Hi, I'm Martin Wilkie, and I'm a renal physician from Sheffield. And I'm very grateful to you for inviting me to participate in the Mansoura Nephrology and Dialysis Unit Conference update. I'm going to use for the slides a session that I presented at the EDTNA Baxter Symposium on the 6th of September. So the content has been prepared for that, but essentially it covers the topic of the modern application of peritoneal dialysis. And I'm going to talk for about 20 minutes. So these are my speakers honoraria. So what I want to cover in the next 20 minutes are what's meant by the modern practice of peritoneal dialysis, to talk about why, in my opinion, every patient should have the possibility to choose peritoneal dialysis as a modality, to describe how survival rates are now improving enormously for peritoneal dialysis and indeed outpacing those for hemodialysis, to understand the importance of the patient perspective in achieving goal-directed dialysis that really supports life participation, and to talk about some of the clinical practices that can support a modern PD program. So this slide's important. It comes from the US RDS, and what it looks at is the prevalence of renal replacement therapy modalities across a basket of countries. And you can see at the top, Hong Kong, where about 40% of the prevalent dialysis population are on peritoneal dialysis, another 40% transplanted, leaving 20% on center-based hemodialysis. If you cut all the way to the bottom of the slide, you can see in Japan, really more than 90%, 95% of the prevalent population are actually on center-based hemodialysis. So big differences between countries. I would say that in Egypt, the large majority of dialysis patients are on center-based hemodialysis. So you can see in between, you've got the United Kingdom, for example, where peritoneal dialysis is really probably about 7% of renal replacement therapy, but actually a large tranche are transplanted. So transplantation, can make up a really big impact on this population, but you can see big variations. So where you see variation, you have to ask yourself, why the variation? Hong Kong, Colombia, Thailand, not on this slide, just show us that it's possible to have a really large PD program really effectively. And indeed, data both from David Mendelsohn and Matt Oliver in different studies have looked at suitability for people starting dialysis in terms of whether they would be potentially eligible for peritoneal dialysis. And it shows that, again, about 3/4 of people with kidney failure have no absolute medical or social contraindications to peritoneal dialysis. So the mechanism there is that PD could be much more widely used than it is already. And indeed, in the pandemic, we learned that dialyzing at home enabled isolation much more effectively than dialyzing at centers where transmission of infection was a greater risk. So that's food for thought for us as we think about optimizing people's opportunity. So comparing traditional peritoneal dialysis in this slide on the left with the modern practice of peritoneal dialysis, you can see there have been big changes. If we look at therapy choice, we can see that traditionally we used to identify people and say, you're suitable for PD, why not have PD? These days, the approach is far more focused around shared decision-making, talking with patients and their families, educating them, enabling them to be involved in making the choice. Then when it comes down to how we treat patients, previously, it used to be much more opinion-based and prescriptive, in other words, saying this is what we do for everyone, if you like. These days, we've got much better evidence than we had before, particularly with large cohort studies such as dialysis outcomes and practice patterns, peritoneal dialysis outcomes and practice patterns, etc., supplemented by randomized controlled trials, registries, etc. So we can provide much better evidence. We want to be much more person-centered. And then when it actually comes to delivering the prescription, again, our focus is much less on urea itself and much more on the multifactorial components that influence the patient's outcome, such as volume, nutrition, symptom control, and so on. And then, of course, these days, in terms of monitoring patients, we have the remote monitoring tools, which are helping us there also. Now, why do people choose home dialysis? And this is a really important paper by McLaughlin from 2008, published in NDT, qualitative study asking people what mattered to them. And you can see from that work that the things that people articulated about why they wanted to dialyze at home were around freedom. They wanted freedom of time, freedom to travel, freedom in terms of flexibility. They wanted lifestyle, ability to adapt their lifestyle, their treatment around their lifestyle, rather than lifestyle around their treatment. So, they want to be able to continue working, continue attending college. They wanted reduced need to travel to the center, all those kind of things. And they wanted greater control. They wanted less dependence on the hospital and on the hospital staff and the doctors. They wanted to make more decisions about their own care and be in charge more effectively. And these key attributes identified those people who selected self-care and indeed home therapies. Now, what matters in terms of dialysis? This comes from the standardized outcomes in nephrology study, and it's been done in PD and HD and so on. And this is an approach looking at systematically at the outcomes that matter and going through it with healthcare professionals, patients, carers, and so on to try to prioritize these. And you can see in peritoneal dialysis, the things that matter have been articulated as infection, cardiovascular disease, mortality, technique, survival, in other words, staying on your chosen therapy, and life participation. So we need to remember those as we go forward. These are key domains for us to focus on. And then if we just drill down on those priorities for a moment, patient and caregiver priorities. This is a paper by Karim Manera, another qualitative study. And you can see the themes that matter to people at home and peritoneal dialysis. They're concerned about their health. They're worried about maintaining their social function, their role in their family, their work, and so on. They're very concerned about what their responsibility is and what's out of their control. They're concerned about the need to be constantly vigilant. So all of these different themes are impending on them, if you like. And then how do they prioritize these? What really matters to them? And you can see again, as we saw from Song, that morbidity and mortality matters, that lifestyle and functional outcomes, what can I do? How can I get on with my life? Managing symptoms really matters. Interestingly, biochemical parameters are prioritized least. Patients care less about their phosphate and more about whether they can spend time with their families, get on with their work, do the things that matter to them. So it's interesting to see how these things are prioritized by patients and carers. Now, what about survival? Survival and peritoneal dialysis. How does that compare with center-based hemodialysis? So this slide just shows you a summary of registries around the world. We've got the Canadian Organ Replacement Registry, the US RDS, the Danish Society of Nephrology. There's also the EDTA ERA, the Canadian Society, the ANS data, and so on. And all of these registries show an early advantage for PD compared to central-based HD. In the first couple of years, advantages for being on PD. Now, of course, these are not randomized controlled trials. And the reason why we need to be aware of that is that selection bias means that sicker patients tend to dialyze in hospital. So we need to be aware of that. Having said that, what this data tells us is that PD is at least as good as center-based hemodialysis. Now, more recently published last year, this propensity scored meta-analysis of 17 studies by El Sayed, published in C. Jason, really important. And this uses propensity scores to do the matching, if you like, between PD and HD. And you can see, to cut to the chase, using that sophisticated approach, there was no difference between mortality between PD and center-based HD, whether it was Europe, whether it was Asia, whether it was North America, whether it was non-diabetics or diabetics. So I think we can put the mortality question to bed when we have this discussion. So moving on from there then, if it's not mortality that's the driver, what is the driver? Well, the things that matter to patients are the drivers here. and life participation is prioritized as being key. So what do we know about life participation? What we know is that lots of studies have shown that being able to dialyze independently at home can really enable people to get on with their life more effectively and have advantages for quality of life. And you can see the reasons why on the right: ability to travel, ability to continue daily activities, to do APD, automated peritoneal dialysis, when you're asleep, allowing people to work or attend school, less time attending the clinic, and indeed potential impacts on caregiver burden, although that's a really important theme that we must not ignore, caregiver burden. So last year, again, another systematic review looked at 21 studies comparing PD with center-based HD, looking at 3 different instruments: the SF36, the EQ5D, the KD-QOL, and in all of those showing advantages. So the conclusion there was, from this systematic review, that PD had higher specific health-related quality of life overall than HD. There were, of course, components that were different, but I think broadly, again, this gives us confidence to say that not only is PD associated with at least good survival, PD is probably associated with better quality of life. Now, when we think about enabling independence, it's really important that we think about the person at the heart of care. And this schema, which comes from a study by Alison Tong, a qualitative study, looks at how we enable that, or how we inhibit that. How do we enable independence? How do we enable people to be independent when they're doing their therapy? And so there's a few domains here for us to think about. If we make the schedule too restricting and limit people's freedom, then that prevents them from feeling independent. So we need to think about how to enable them to take control and adapt their schedule so that it fits around their lifestyle. What about their relationships? Supportive relationships help to enable that independence. Their family, their carers, but also the healthcare team. So providing support, helping people to grow, gain confidence, and become independent. Lacking clarity is a problem. So if we give people mixed messages, poor quality information, confuse them, then they're less likely to be able to be independent and to gain self-management. And then look about this, the things that we can do, again, to enable independence: personal growth through adjustment, enabling people to become resilient, to adapt. Humans are amazing in the way they adapt to their circumstances. So you can enable people to adapt to their circumstances and gain confidence. We can help them to overcome constraints by working with them. And through a rehabilitative approach, enable them to regain lost vitality. So there's all sorts of different steps we can take to enable independence. And furthermore, we can think about assisted peritoneal dialysis. This is a study again by Matt Oliver, and it looks at the barriers on the left-hand side, the left-hand panel, that people experienced when they were thinking about peritoneal dialysis. And in the right-hand panel, you can see in the orange, this is from Canada, the orange bars, if they were enabled to have home care, in other words, some support coming into the home, that there's a greater chance, greater PD eligibility and greater receipt of peritoneal dialysis. So again, finding ways of providing carer support to overcome some of those barriers is helpful. And then to turn to the International Society of Peritoneal Dialysis recommendations for prescribing high quality PD, published in Peritoneal Dialysis International last year. You can download this, it's free and accessible to you from ispd.org. And there they are, they're looking at the different domains around prescribing. So I told you we've moved away from focusing on urea clearance to thinking of a more person-centered approach. Shared decision-making in the amount of treatment, when the treatment's done, modifying the prescription for the frail, for those with poor prognosis, aiming to preserve residual renal function, thinking about holistic management in terms of volume status, nutrition, and a whole range of other components. So it's a more holistic approach that we're thinking about there. So now, in the last few minutes to the left of this talk, I want to cover some of the modern practices. This is a slide by Hatay from C. Jason, published in 2017, and it looks at the Australia-New Zealand centres, and you can see a variation in the hazard ratio for technique failure across those 51 centers. And what I'm just showing you on that slide is their adjustments. So basically, the unadjusted is in the green, triangles, big variation. If you adjusted for patient factors, the variation changed to some extent, but not hugely. But if you adjusted for center-based practices, then the variation became much less. What this is telling us is that it's our center-based practices that make a big impact on outcome. That's what we need to bear in mind. It's not so much the patients, it's how we look after them. And on the left-hand panel are the causes of technique failure for peritoneal dialysis: mechanical, leaks, hernias, the catheter, infection, psychosocial, that support, clearance, how we prescribe. And how do we drill down into these? Well, we've got management tools that can help us with these. Icodextrin helps us with managing volume, and you can see from a systematic review there, impact on uncontrolled volume overload events. So good evidence for icodextrin. We've got evidence for preventing infection. This is from PDOPS, and it shows the use of antifungal prophylaxis across different countries. And we know that the use of antifungal prophylaxis is associated with reduced fungal peritonitis when people are having antibiotics for other reasons. And if you look, Australia and New Zealand are routinely using antifungal prophylaxis, whereas in the UK, we're hardly doing so at all. So what this tells us is we can apply the evidence systematically to improve our patients' outcomes. This tells us about PD catheter insertion, showing us that if we use the advanced laparoscopic techniques, that can reduce the risk of catheter obstruction or catheter migration. And this slide tells us about incremental PD, adjusting the prescription to the residual renal function. So there are a whole range of things that we can do to apply higher quality therapy to improve our patient outcomes. And for example, if we use incremental PD, we can start people when they have a degree of residual renal function and reduce the burden of treatment for them. For example, giving them a couple of nights off on the APD machine or doing fewer exchanges, but adjusting the therapy going forward as the residual renal function declines, increasing their therapy as necessary. And then the final part of the talk is a brief mention about remote technology, remote monitoring. The future is digital. This is a slide from Columbia. This is a cohort study looking at the impact of remote APD monitoring on technique failure. And they showed a reduction in technique failure in this study by patients being remotely monitored using the share source APD system that Baxter has. And here on this slide is a number of events that were different in the two groups. For example, fewer inpatient visits where people had remote monitoring, but also they were able to adjust the program more effectively. They had fewer alarms and so on. So there's just a number of advantages there that we can see. And indeed, through the pandemic, for us, being able to monitor our patients remotely made a huge difference. So to summarize at the end of this talk, modern peritoneal dialysis practice is achieving different results. We see that survival is at least as good as center-based hemodialysis, probably outpacing it. Quality of life is better. So we've seen big changes in the last 2 decades in terms of the delivery of peritoneal dialysis. And we've done that through applying evidence and using the tools that we now have of modern PD. And I put them at the bottom of the slide. For example, using automated PD, using icodextrin, having modern techniques in terms of catheter placement, using incremental PD, remote monitoring, these different components, if you like, that enhance the quality of the care that we can deliver. So to summarize, therefore, we can deliver a better quality of PD now. We should be asking ourselves, why can't the large majority of our patients have access to this home therapy, which gives them independence? So thank you very much for listening, and I'll be happy to take any questions that you might have.
Thank you, Professor Martin. Any questions for Professor Martin? I think the best thing in the modern PD is the modernization of the relation between the patient and the caretaker, which has a very good impact on the outcomes of PD, hence the name modern PD. That's how I understand it. Any questions for Professor Martin? Well, nothing?
Thank you for inviting me to talk at this meeting. It's a great honor.
Thank you very much. I have some questions here for Professor May. The first is, is HIF or HIV approved in Japan and not in the USA? Why? Huh? HIV is approved in Japan and not in the USA. Oh, not in the why?
I think it's coming. It's already approved. If you speak about the propyl hydroxylase inhibitors, yes, it's already there. It's coming. It's coming to Egypt. It's on the way to Egypt. Well, the studies started in Japan and in China, and they were approved first there, but they are going on, and I believe they will be approved soon.
Well, the second question, can HIV cause or increase kidney fibrosis?
No. However, I think kidney fibrosis is not one of the feared problems that can happen. I think until now, there have been no significant difference in the side effects between those who received the HIVs and those who did not. But I also believe that to decide on something like that, you need a longer follow-up period. So we're still awaiting longer follow-up period, but this is not an expected complication to occur.
Thank you, Professor May. Professor Sharkawi is us or not? Professor Magdi Sharkawi is not. So the proper question for him is not allowed. Any question for Professor Hisham Said as regard membrane? Okay. Thank you. We have to close the session, and many thanks, and we'll proceed to other sessions.